Good afternoon and welcome to Talk Time from Dr. Stephen's Hospital today being the WHO World Patient Safety Day. We're kicking off QItalktime for autumn-winter today with Dr. Philip Crowley, so thanks very much for joining us. And we're delighted to have lots of new QItalktimers online with us today, and fantastic that you can join, and hopefully you have a room full of people where you can get the conversations going on quality improvement. So today we've Philip Crowley with us. He's the National Director of the HSE Quality Improvement Team. Philip is a doctor who's a GP, worked abroad, particularly in Nicaragua and in the NHS, tackling health inequalities. So he's trained in public health medicine and has worked extensively across the health system. He worked 6 years as Deputy CMO in the Department of Health and continues to work today as a GP and is part-time. In his other role with the National Quality Improvement Team, he takes a strategic and sustainable approach to trying to build quality improvement and leadership across the HSE, and has adopted a framework based on 6 drivers, which is the HSE framework for improving quality, which is available on the website for you all to download and look at. So we will be talking today about the National Quality Improvement Team's new strategic plan, which is 2020 to 2024, which links really nicely with the WHO patient safety strategy as well. And we hope to partner with services to enable improvement across a number of areas, and Philip will allude to that later on in today's talk. So just some instructions for you, and some of you might be new online. You can listen over the phone, but also over the computer. The phone connection is normally better. The event number is 849-013-27#, and we have Naomi here with us today, who's managing the chat box. So we want to make it as interactive as possible. We'll have plenty of time for questions or comments throughout the webinar. When you are typing in the chat box, if you can type to all participants, that would be brilliant, just so that we can see who's online. If there's a few of you in the room, certainly make sure to tell us if there's a few of you there, so we can get an idea as to the number that are online. So please do, any questions, throw them in the chat box and we'll deal with them throughout the webinar. We're also active on Twitter, so @QItalktime is our handle, so please use that and take a photo, tweet @QItalktime. That'll be brilliant, and get the conversation going. So without further ado, I'm going to hand over to Philip, who'll take us through some content. And if any questions come up as you go, we'll interject with those as we go. Okay, thanks very much, Philip.
Great, listen, it's lovely to be with you all today. A really big day, the first Global Patient Safety Day, one where I think all of our commitment to not harm and to provide the highest quality services is really given a global focus, and one which I think I really welcome, because it's a global issue. It's an issue in every country. The challenges that we face are challenges that all healthcare systems face. So I think it's a really important day, and first of presumably an annual Global Patient Safety Day, and one which I think we've organised quite a lot of activities around, which we're going to touch on as we talk this morning. So in terms of it being, the World Health Assembly's adoption of this as a global health priority, this happened in May 2019, and it's basically, the commitment is to put patient safety at the heart of universal health coverage, which is a global health priority for the World Health Assembly. I think it's really based on this understanding that while it's essential to have access for everybody in the world to health services, and we have access challenges ourselves, it's not adequate to have access to services that are going to harm people or are poor quality. So it's really bringing quality into the centre of the global health challenge, and I think that's something that WHO has gradually adopted, and something that I really welcome. And the 17th of September is World Patient Safety Day. So for us in the HSE, obviously we work nationally in the health services and locally. A lot of our work is with local services. We also have a global health perspective, and I think that's more important than ever in this day and age, to be honest with you. We have lots of challenges that are truly global in nature. and we will only effectively deal with them if we work globally through organizations like the WHO. Challenges are very obvious ones like climate change, but also issues of migration and communicable disease control, all issues that are really global in nature. And we very much recognize that in HSE, and therefore we've established a global health program. Just to give you a little flavor of it there, we've two particularly vibrant health service level partnerships with Mozambique and Ethiopia, where we've been doing work on training people up in QI and pressure ulcer prevention, and it's been a very wonderful experience for us to work with such amazing people across Africa, and something that we've learned an awful lot from. And I'll come back a little bit to that in a moment. But really, today is a day where the WHO asked us to speak up for patient safety. And it's a day where I think we will re-engage with our commitment to do that. Through doing that, we really need to engage patients in the efforts to improve safety, and of course, all of our staff. I think it's important to remember that we don't have to work in a perfect workplace or have the perfect circumstances which to change something. We can now and try and gradually, bit by bit, starting small maybe, improve things around where we work, improve things that we can influence, and try and change things, because I absolutely know that the one thing that really motivates us and keeps our morale up is when we feel we're being able to do a good job. And it's wonderful to see how people feel when they present their work, when they've improved something. So it's a great thing to do, and so many of our staff actively do it every day of their working lives. But equally in relation to speaking up for patient safety, we very much embrace this global movement. We just feel one small part of it. We've been doing work on medication safety with the WHO as well. A number of us are working with the WHO to advise other organizations in other countries around quality improvement. It's very much a global perspective that we bring to our work.
And Philip, just to interject there, just to say over 90 logins today, so we want to see that chat box getting going. So even if you wanted to share over the chat box some examples of how you integrate the patient voice into patient safety, I think that might be a nice interaction over the chat box during the webinar.
And everyone will be able to see that then.
Everyone will be able to see it. So fantastic to have so many of you online. So just don't be afraid to get the chat box going.
Great. So today, we've obviously been doing a number of things. This is a centerpiece of what we're doing, and it's obviously part of our ongoing webinars where we seek to nurture and maintain a broad network, which we would feel hopefully part of, of people who really are trying to work to improve care every day of their working lives, as I say. So we've been doing a number of things. We'll have a tweet chat this evening at 9 o'clock on speaking up for patient safety. I'll tell you a little bit more about that near the end of the interaction. The link is there in the chat box. A lot of social media today around patient safety. We're advertising the ERS Human documentary, which the WHO has made available to everybody. We're lighting up buildings the colour of orange, including our own building here in Dr. Stevens. And there have been multiple local events to mark, I think, what is a really important day in the calendar for all of us. So why are we concerned about patient safety? I mean, we do complex work, increasingly complex work with our patients. It's risky work, and sometimes things go wrong. And that's devastating for patients and families, and devastating for staff as well. And we also work in stressed environments and make safety a challenge. So I think it's really important that we really focus on how we reduce harm, how we increase safety awareness, and try to avoid the avoidable harm. Not all harm is avoidable, but a lot of harm is. And our own study of adverse events demonstrated a 12.2% rate of adverse events and a chart review in our hospitals. Varying rates of harm in international studies up to 16%, costing a large amount of money and a lot of hardship and pain to patients and families and indeed staff. So it's a massive priority for us, I think, and we readdress our commitment to address it here today in this Patient Safety International Day. So we've developed a strategy for quality improvement that hasn't been published yet. It needs to go through various reviews here and elsewhere, but the things that we've identified as core elements to develop a safety culture and a QI-focused health service are developing real partnerships with their staff and patients, collaborating and sharing learning, investing in quality improvement and in safety, committing to training all staff in quality improvement, and we're going to work to ensure we can do that. Work on relationships and culture so the staff feels valued. We all know what that feels like and what it doesn't feel like when it doesn't exist. Working with their managers to create a work environment where staff feel enabled to work on improving care as they see fit in the area that they're expert in. All staff know a lot about their own area of work, and only they really can improve it. We use measurement for improvement approaches so as we can really use data in a way that charts improvement over time and keeps our commitment to improvement going when it gets tough. Ensure we have quality at the centre of our management and governance as well, and that's what we're talking about, it's what we're engaging with. Work to integrate services that are silo-based or not quality-based, and make sure they're accessible and equitable. Because again, if you can't access services, then they're not quality either. And partner with communities, I think, contribute to improving the social issues that determine poor health outcomes for a lot of communities and a lot of individuals. So, in the current context, as I say, we have a draft QI strategy, which is on the next slide here, and that's something that we'll be circulating widely in a short period of time. But something that's very close to sign off is the patient safety strategy, which has been developed by the Quality Assurance and Verification Division in partnership with ourselves. This is not a top-down document. This is a document that seeks to build on the kind of work that everybody's already doing, the work that the clinical programs are doing, the work that we do, and the work that QAV have been doing, to really pull things together into a programmatic approach to patient safety, and not to reinvent the wheel, but to really engage people in their own work and support people in their own work locally and local organisations to improve safety. And I think it's going to be a very key strategy and one that we will be putting our full effort and force behind. So a little bit about the National Quality Improvement Team, just to kind of give you a flavour. You'll see from the next slide that it's not terribly well gender balanced, but that's the nature of our health services, which I'm not sure what it says, but it's the fact that so many of our staff are female, and we have a great team. The plan is going to cover 2020 to 2024 when we publish it, probably around the start of the year, and really trying to see how we can ensure that the work that we all do gets knitted together in such a way that quality improvement becomes something that's owned by management, leadership and staff at all levels of the organisation, and not just the quality improvement lead or the quality improvement specialist, but everybody. And I think if we manage to achieve that, then I think we'll find we're working in environments that are much more satisfying to work in and safer and higher quality for our patients. So we've achieved quite a few things nationally in terms of patient safety through using quality improvement methods. We've done a lot of work in partnering with people who use our health services. We've got patient panels and patient safety, Patients for Patient Safety Ireland is a really important group that we work with. We've been doing work on medication safety, training people on how to improve medication safety. We have the No Check Ask campaign, which we have some of the leaflets for here. You may be aware of this. It's just a safety program that's very much linked to the WHO's global commitment to medication safety. And it's really about empowering patients to ensure we all know exactly what medications they're taking, and we reduce medication errors, which are a significant source of error in our healthcare system.
And just to say on that, all of the resources in relation to the No Check Ask campaign are up on qualityimprovement.ie on the Med Safety tab on that website.
Excellent. Thank you. So yes, and other things we've been doing, we've been working on pressure ulcers to reduce this terrible harm that we sometimes occurs to patients in our healthcare system. And we've been working on, through the medication safety program, to reduce avoidable blood clots for patients who've been admitted for various procedures and medical illnesses. We've been doing a lot of work on developing leadership skills, particularly in partnership with the HR division here. We've been training people in quality improvement, large numbers. We've been engaging in Schwartz rounds, which are an initiative to try and help people deal with the emotional aspect of delivering care. We're doing a lot of work around decontamination and clinical audit training as well. So, as I say, we've been active. All of this work has really been done in partnership with yourselves. We don't work on our own. We work in partnership. Absolutely.
Just to say, some of you are having issues with sound, and there are a number of different options. The phone number and login number Naomi has put in the box, so please just dial in and you'll be able to hear perfectly over the phone or plug into your computer. Thanks. Some of you are sharing how that works. Sometimes first time around, it just takes a little bit of getting used to, so do persevere. Once you've done it once, it is easier going forward. Thanks. Thanks, Philip. Sorry.
Great, no worries. So this is just a little visual summary of how we're going to marshal our resources that we have to support you in the front line in improving patient care around patient and family engagement, work around global health, as I've mentioned, clinical director program, evidence for improvement, QI Connections, which is really trying to remobilize a kind of a movement around quality improvement, some of the sustainable QI programs which I'll come back to as well, and a school of QI. So a whole series of different initiatives that we will be working with you on over the next years of the strategy. In terms of sustainable QI programs, just to say the priorities we're currently working on, and we will clearly evolve these as the system requires us to do so, but we'll be working on falls. We've already been working on pressure ulcers for some safety. QI for healthcare boards, trying to get healthcare boards really on board with quality improvement and safety, and working on the deteriorating patient and early warning systems. So they're the main areas of work that we'll be working on in partnership with yourselves as part of under the umbrella of the patient safety strategy. So in terms of the School of QI, the School of QI program, that's really building on the diploma that we do in partnership with the College of Physicians and all of the skills development work we do in working with groups to improve the quality improvement skills in order to improve patients. And we'll be developing various offerings with different groupings depending on the demand to improve their ability to make change happen using improvement methodology, because I think historically we've kind of tended to just get on with things, just do it, make the change. But I think something that we kind of need to remember sometimes is that we may have a really good idea, but it may not work. But that's why having an improvement method, which is what we teach, is very useful, because then we can test our idea, and if it doesn't work, we can modify it, and then when we find it starts to work with a small test change, then we can expand it and implement it, rather than just ramming ahead to implementation at a time when we're not really sure if it works.
Maybe one thing to add in with the School of QI is, Philip, I think for our listeners would be really practical for use. We are in finalising a QI toolkit, which is a QI improvement methods toolkit, which is really usable, and we've tested it in the NRH with our colleagues there, and I know Valerie's online. So it's tested and tried, and we've developed that a little bit further, and it will be a toolkit that I think will be really useful for all staff if interested in improvement. And we will do a webinar on that, which will probably be one of the next ones, and we're using that toolkit with any of our programs that we're doing in terms of our collaboratives, our diplomas, etc. So it's interweaved throughout all of that, but I think you'll find it really useful. So we'll let you know through email when we have that done. And I see a question is coming in here around the school, which I'm just trying to see. So where is the School of QI and how do you get involved? Good question. So
yeah, well, the School of QI is led by Dr. Mary Brown. There's a small team of people who develop learning opportunities for different groups. For example, the hip fracture database have a number of hip fracture coordinators around the country, and they came to us and they asked, could we embed QI in the work that they do? the audit, then they try and improve on the back of the audit. And so we're going to work with their coordinators to train them up in QI and enable them to use those skills to implement change to improve care of people who suffer hip fractures. So that's just an example of somebody comes in, and within our ability, the number of people we have available, we will try and run a short program, a taster session. The online resources. It's not a physical school per se, it's a virtual school, but a lot of very highly capable people who very high capable will try and support you in your of quality of care.
And just to say, the school is linked into all of our training programs, so in terms of the collaborative and diploma, etc. So the school, we link across our team in terms of the provision of training.
Yeah. And the whole QI training is central to the earlier set of programs, for example, around falls and pressure ulcers. So we bring the skill set into everything that we do and try and train people up when they engage with us on the different programs.
Great to have Melissa Casey online from Grange Gorman Primary Care Centre, who are participating in the RCPI diploma, which we deliver in conjunction with RCPI, and they're developing their project. So hopefully you'll get some tips from some of the content today, Melissa. Thanks. And
I think I may have met Melissa just recently. Yeah.
Yeah. Great. Okay.
So yeah. So that's the School of QI. Another thing that I suppose that we're aware of is we've trained a lot of people in QI, and we'd really like to kind of keep them engaged in improving care. Because it's quite easy to kind of train up, improve something, and then get back to work and get kind of a little bit bogged down in work, ground down to a degree with the pressures of work, and then kind of get a bit stuck again. So we're trying to develop various methods to network people who are involved in quality improvement, who would like to be involved in quality improvement, create networks of community and practice. This talk times will be part of that. We'll be developing a whole series of communications, and online training will be made available to everybody over the next year or so. That's obviously a bit of work to be done to develop an entire online program, but it'll be very much backed up by the toolkit that Roisin has already mentioned. And we'll continue to support Schwartz rounds around the country, which, if any of you have participated in them, the feedback we get on them is very, very positive.
And one thing to say, as part of the QI Connect, we're trying to improve our communications out with everybody in terms of what our offerings are. For example, up-and-coming training programs, webinars, different things that we're developing. So over the next few months, there will be a newsletter which will come out on behalf of the National Quality Improvement Team, which should keep you more up to date with in terms of activities that you can connect into.
Yeah. So then, in terms of other areas that we're working on, I don't know if you look at the performance report that we produce every month, but it's very dense. It's a lot of sheets of data, it's a lot of point-in-time data, and it's often just compared to the same point in time in the previous year. So this is not data that we think is particularly useful for improving patient care. So we've been working with the leadership team to incorporate a measurement for improvement approach, really, which involves things like statistical process control charts, which some of you will be aware of, and funnel plots. So disaggregating data as well, so as you can see the performers as well as the ones who are struggling a little bit, and learn from both good practice and practice where things could be improved. So we're really doing a lot of work in that space. We've done some work with the new HSE board on that as well, and we'll be hopefully we've provided training in the past, so we're going to provide some more training on how to kind of develop the charts and how to interpret them, more importantly. They're relatively straightforward once you get the hang of them, but they really transform how we look at information, and I think would really be a game changer for our health service if we were able to really embed them in our healthcare system. So we intend to really work hard on that over the next few years.
One of the things, Philip, I think that might be useful to our listeners is, as part of the evaluation of QI Talk Time, we asked people what topics they wanted included in Talk Time webinars. One of the things that came up a lot was measurement for improvement and evidence for improvement, and we are planning to, in our schedule, to have a measurement series, where we will go back and recap like a refresher course and perhaps even do some more technical pieces on SPC charts, etc. So that will be coming up in the timetable as we go forward over the next few months.
And that's an example, I guess, of how we can use webinars, which is just part of nurturing people's QI skills, giving a bit of an update for people and refreshing skills that they've already learned, maybe teaching people some new skills as well. So to kind of build this community of improvers, which I think ultimately, if we can build a critical mass, we'll really start to see a health service evolve into a really quality-focused health service, which is what I hope we can achieve. So just in terms of other things that we're doing that I think are really crucial, obviously is, I don't know if I'm sure you'd agree, we really shouldn't be doing anything in relation to how we design health services or deliver them without really involving the people who use the services, be they service users or patients, families, carers. That's really at the core of everything that I think we believe in here. I know most staff I talk to completely sign up to that and adhere to that kind of philosophy, because it's extraordinary how you can really mold things in an intelligent way if you involve patients from the very start, and you get a lot less things wrong if you do so. For example, our management team have 2 patient representatives. So if we're making key strategic decisions, we will always involve patients and make sure that they keep us in line with the service user perspective. And so we're doing a lot of work in this space. I've previously mentioned the Patients for Patient Safety Ireland group, National Forum and National Patient Representative Panel, and we work to support the services in their efforts to involve patients. And it's great to see how many people contact us looking for advice and support on how to involve patients. So I think it's really something that's really core to how we do our business these days. But I think we can always improve it. And I think one of the things I always think about patient engagement is the key measure is to think about is, okay, we're engaging patients, that's good, but we really have to ask the question, and maybe ask the question of the patients themselves, what have they seen that's changed, or what's done different as a result of the patient's involvement? I think once we start to see that, that means patients are not only engaging, but they're influencing and they're changing how we do things. And I think that's really, then we'll know that we're really engaging patients in an effective way. That would be a real measure I would have.
So there is a question here from Patricia in Our Lady's Hospital, Our Lady of Lourdes Hospital, yeah? Just wondering if there's a short version of the performance report available.
If you look at the performance report online, there is up front all kinds of summaries. Truth, the more you summarize it, that's partly what can be the problem with the data, is the more you summarize it, the less detail you have, and therefore you can miss some of the subtleties of what the data is actually telling you. So in other words, when you summarize it in aggregate number for the whole health service, we don't know if there are good and bad in that, and generally there are. We always see variation when we summarize. But there are summaries contained within the report, but it's a single report that's produced every month and is available online. It's worth having a look at, and any support for kind of moving it more into the measurement for improvement space would be welcome, because that's where we're going to with it.
Joanne Finn has put in a comment about the NHS Plot the Dots campaign. It's worth checking out. They're bringing it nationwide to boards. It's an excellent free online resource. Thanks a million. We'll have a look at that. Anya Burke has commented on QI is frequently dependent on collecting data from incident reporting, which is notoriously poor. If appropriate, can address how to improve and encourage this?
Yeah, I mean, that's an interesting point. I mean, we have obviously the system, the National Incident Management System, which is housed in the State Claims Agency. And I think, you know, if you look globally, it's kind of up there in relation to national incident reporting systems. That's only to say that it's as strong and as weak as any incident reporting system. Most incident reporting systems would find that a significant degree of underreporting. Different percentages of incidents are not reported in different systems, but there's a significant degree of underreporting. That's not to say that we can't use the data that is reported, and that's what I always feel about data is you'll use the data you have. By using it, you'll improve the reporting just by using the data at all. And we found that with a number of different initiatives where we started to use data that we haven't thought was really very robust. It becomes more robust as you use it because people don't want bad data out there, so they start improving the data that goes in, and then we get better information out. So that would be my main advice in relation to that, is to really promote people locally. If there's an adverse event, it should be reported. It's only for learning. There's no punishment applied, and we must learn from when things go wrong. If there's anything we should be noting today on national patient safety, that we must learn from when things go wrong. It's one thing that patients say, when something goes wrong, is they want to be treated with compassionately. They want what was wrong explained to them. They also want some sense and a clarity that we're going to learn from what went wrong, so as other people are less likely to be harmed in the same way. So I think, we must learn from adverse events, and if we don't report them, that's the first step. And we won't be able to learn from them if we haven't reported them, because we won't know that they happened in the first place.
And just to say, there is a really useful webinar that we've done previously, After Action Review webinar, which was done in conjunction with the Quality Assurance Verification Division. And I must say it was really good information in that with respect to reporting adverse events and helping to, promote that open disclosure and that kind of cultural piece around everyone sitting around and discussing and trying to troubleshoot what actually happened. So if you wanted to look back at that, it is online on the QItalktime page, both the slide set and the actual recording, so you can watch it back, and that might help with your issue. Siobhan Gallagher, it may help if people understood the outcome of completing incident reports. Very often the attitude towards incident reporting is that it sits somewhere and is never really acted upon.
Yeah, I mean, that's partly the issue I was referring to when I talked about the QI strategy. So long as safety or improvement is that department's job, it's the Department of Safety's job, or the safety job, or the safety lead's job, then you're right. I think that's what happens. Something gets kind of passed over and job done. So people don't really own issues. They escalate them or they refer them. I think it's really incumbent on people who fulfill these safety and quality roles that they don't assume responsibility for all safety and quality in their space. What they do is they're an enabler and a supporter, a trainer, a facilitator to ensure that everybody can fulfill their own role in relation to ensuring safety and quality. And in relation to actually completed reports, it's clearly critical that there's a closure loop. It's a bit like an audit. There's no point in doing a report and having recommendations if we don't act on them. Where having some governance around this is really important, and that's why if you look at our quality improvement framework, you'll find that governance is one of the 6 drivers. And that would mean that you'd have a quality and safety committee that would be reviewing incident reports, ascertaining whether they've been acted on, and indeed shared outside of a setting, because we can learn from what happens locally into implications for other settings as well. So I think if you look at the framework, you'll see the kind of drivers that would stop completed incident reports being ignored. Nobody wants that, and that's not a safe practice.
Great, thanks for the questions. Keep them coming.
Keep them coming, yeah. So, in relation to the whole patient engagement, we'll go to the next slide. We are also doing some specific work in areas such as open disclosure, which obviously had a lot of publicity recently. Whatever about the publicity, it's been a wonderful program of work run by Angela Teisel, massive amount of training done, more so than any policy I can really ever remember in my 9 years in the HSE. So one that we're very proud of. Obviously, it doesn't guarantee that open disclosure happens satisfactorily in every setting at every time. What we do is train people up, train trainers, have open disclosure leads, and that work is continuing, and we're adapting to new legislation and continuing that training work and making sure that empathetic disclosure happens when something goes wrong. A really important thing in the area of safety, a thing that patients often highlight, is that the hurt of the harm is compounded by how things pan out in the immediate aftermath of the event. And the other area we're working on is assisted decision making, which is obviously, and consent, which is kind of, if you like, part of that. The Assisted Decision Making Capacity Act of 2015 is one that we need to train people up in, get people prepared for, and really what it does is it ensures that people's capacity is respected and people's ability to make decisions for themselves is maximised. Not something I think that has always happened in the past. So a bill that we really welcome, and one that we will be doing a lot to support you in dealing with. The only other areas I'd like to just briefly tell you about is the Global Health Programme, which I've already touched on. Something where we feel we benefit a lot from learning from staff in colleagues in other countries with less resources. It's amazing to see what they can do with less resources. The run chart there, photographs there, there's a safety cross here on the left-hand side. So things that we do here that we know work here, we can adapt and work with people, Mozambique and Ethiopia in this instance, but increasingly with other countries to ensure that they benefit from what we've been learning and that we then learn from them and benefit from what they learn. And it's a really wonderful program and quite fitting kind of program to highlight on this particular global day.
Before we move on, Philip, we might address a question from Deirdre Carr. She's asking around focus of this, and the focus seems to be on the medical model of care, and what about QI for social models of care, for example, intellectual disability services?
I mean, that's a very good question and a welcome reminder, if you like. I apologise if it has appeared entirely medical. It's not medical at all. We've done a lot of work in social care, and we have a diploma now specifically dedicated to the social care sphere, and we've adapted it to the needs of the teams who come through that diploma. And I've met with the CHO, COOs, and really recommended to them to use that diploma to train up key staff for themselves, so they can have people who are up in QI that they can rely on, who can then train others in their own organisations, and we can support them in doing that. So we've a big focus on social care in our team. For example, post-Oris Attracta, Maria Lorden-Dunphy and myself formed a team of very capable QI practitioners who partnered with social care to go around intellectual disability services and assess whether issues that were highlighted by the programme on Oris Attracta could happen in other settings, and whether we could ensure that we could work with practitioners on the ground to improve practice. And that's what they've done with a fairly strenuous pan-country programme. And what we've noticed, interesting, is that the HICWA inspections of the settings that we've been working in have gradually improved their inspection assessments, and there's been much less recommendations for improvement because we've been getting ahead of things and actually improving things before we're told to, which I think is really what improvement is all about. I think it's a good example of why we should dedicate time to improvement, because if we don't, we'll be ambushed by events and then we'll have to improve them anyway, and we want to improve them. Why don't we just try and get ahead and try and create a little bit of time in our very busy work schedules to dedicate it to improvement, and then we'll get ahead of some of these issues and some of the issues that the regulator highlights.
Thanks. Another question from Marilyn Veriker. She's asking about what new resources are available for patient safety in mental health care settings.
I think a lot of what we're working on is applicable in all settings. We have done quite strenuous links with the mental health division of the social care division, and we'll continue to explore how we can support them. They're already motoring ahead on a whole series of safety and improvement initiatives themselves, and we've tried to support them in that, and hopefully that relationship will deepen. But there's a lot of resources there, both within the mental health division and our own resources that will be available to you. And if you feel they're not really working for you, just contact us and we can work with you to adapt to make sure that they're more in tune with your work environment. But I hopefully a lot of them will be quite appropriate for what you're already trying to achieve.
I think the HSE patient safety strategy as well, there are groups being brought together around that and how we can kind of cohesively group everything together for different areas. So there's a number of programs, for example, falls, medication safety, etc., so that we're addressing every element of healthcare. So there will be more resources like in the foreseeable future aligned with the patient safety strategy.
But it's a good point to remind us as well, because no more than social care in general, but mental health specifically, maybe historically sometimes not been in the loop or properly addressed when we thought about health service initiatives. But I have to say there's very good people working in mental health, and they work fairly assiduously to make sure that that doesn't happen, and we will work with them. The other program that we have, finally, is a clinical director program. There's always been a history of very strong nurse leadership in our system. We're going to be working as well through Colm Henry's office to support the health and social care professionals leadership, critical group of people we want to really listen to and assume respected leadership roles, but also medical leadership. So we have a clinical director program with non-consultant hospital doctors and consultants to try and build their voice in as well. And I think if we really effectively engage clinical leadership in all its shapes and sizes, both health and social care professionals, nurses, and doctors, we'll have a much better orientated and more intelligently run health service, one that is really led by clinical considerations, clinical knowledge and understanding. That's part of a wider commitment, I think, that we have to collective leadership, and any of our inputs into, say, the leadership program that the human resources team lead is all about collective leadership. So it's not just clinical people who can lead. We've done work through Lisa Tolan in the emergency departments, and through that work called clinical microsystems, different people can lead different initiatives, and porters have led very fundamental changes in the ED departments, security personnel, staff, nurses, doctors, physiotherapists. We must respect everybody's area of knowledge and expertise, and a health system that really effectively does that, it will be a very good health system. Finally, just to say a few little things about why are we doing all of this, what's the point? I guess it's to achieve outcomes. I mean, we can all kinds of processes and things we're trying to do, but if we don't achieve outcomes for people who use our health services where they have a better experience, better healthcare outcomes, reduced harm, where they experience greater collaboration and partnership for themselves, more participatory decision making, then we won't have achieved our goal. That's what we're trying to achieve, partnership with yourselves. In terms of healthcare service organisations, we want to improve the efficiency of services and quality that we really want to try and embed quality improvement in everything that they do, in their governance systems, that they invest in QI, and we support them in that investment, intelligent use of information, and that they in turn listen to people who use their services and their staff, and really promote a person-centred culture of learning and sustained improvement. And that they mobilise the people who they've already trained up in QI, because we've worked with them to train a lot of people, and we want to keep them mobilised and active in the area of quality improvement and safety care. And in terms of people who deliver healthcare services like yourselves, we want to increase your capacity and capability through the School of QI, through the various departments and things that we run. We want to improve your ability to collaborate and have work. Teamwork is crucial to effective healthcare. We want to improve everybody's opportunity to lead improvement. We absolutely fundamentally believe in ability and right to lead improvement, and their knowledge that only they have of their own specific area of work. We want to continue to support these networks that are emergent in different places, and increase joy at work. I mean, that sounds a bit naff, but really it isn't. And if we don't enjoy work, we don't work as well as we would do if we created an environment where people really enjoy their work, felt valued. Finally, for the healthcare system overall, we want to improve a general sense that QI is everybody's job, and that's a route to improving care and quality of services. We have a consistent use of improvement methods, and not just one method, Lean, Six Sigma, the IHI model for improvement. It doesn't really matter what model we use, there's a lot of overlap between them anyway, and they're all basically based on understanding that we don't necessarily know what works, we need to test it, and we need to intelligently analyse our system to embed a change effectively. We want to improve collaboration generally, both here nationally and between each of the organisations we work with. I think we've tended to be a little bit competitive, and I don't think that's something that, while competition can be quite useful sometimes in general in healthcare, I think it's good if we collaborate, share learning, and work together better. So we want to start with that ourselves. work better with our own colleagues here nationally, but also with yourselves. And I hope you find that that's the way that we do work when we work with you. So just a couple of things just to finish up. This is your platform. The webinar platform is your platform. It's lovely to see this has been, and we've more time still to go, but an interactive interaction, which I think is, not just, these shouldn't just be talks, they should be interactions. And with this kind of technology, we should be able to achieve that. And you can share with us what you've achieved, and you can share with us ideas for future webinars. You can participate in some of the future webinars. It's not something that we own, it's just something that we facilitate. And it's all part of a tool that we like to make available to everybody. And in partnership with you, we'll ensure that it's content useful and help them on their ongoing QI journey. And in relation to today, as I say, there will be various activities throughout the day and social media presence and lighting up the colour of orange. But also tonight at 9 o'clock, a number of us will be co-facilitating a tweet chat, isn't that what it's called? Tweet chat, yes, I've done one of them before, so they're quite fun. The way to access it is to search for hashtag QIrelandWPSD. So it's not QI Ireland, it's QIreland, I being a single I, QIrelandWPSD, hashtag before that. Around 9 o'clock, 5 to 9, you'll be able to tweet in, share your ideas, criticize, share a joke, whatever you want to do, and we'll engage with that and create a bit of a community chat around today's day and what we hope to achieve out of it from. Because in a way, a day like today is really important and really valuable, but it's only as important and as valuable as we use it as a spur for further committing to improving safety and quality of care. And I'd like to make that commitment to you all today, and I'm sure you all are making the same commitment by participating in this webinar. So thank you for listening to me. Happy to continue the conversation online for the next 10, 15 minutes. I think, Roshan, you have a few things to say as well.
Yeah. So if there's any further comments or questions for us, please type them in there. We have 5-10 minutes. Just to say, there was 110 logins for today's webinar, which is fantastic.
Great.
So I'm delighted that you could all join us, and hopefully you'll continue to link into QItalktime. And as Philip said, we really want your feedback, and to please do type in the chat box. You can type to all participants or just the host. Comments that I will get. If you've any comments or suggestions for further webinars or how we might improve, please do that. Just to say, we did do a recent talk time survey which was open to anyone to reply to, and we got some great feedback. So over 70% of participants find the webinars extremely helpful or very helpful. So we're seeing improvement over the last 3 years. It has been up and running since 2017. So we're trying to improve the platform every time. So this feedback really helps us. And I suppose this year, really interestingly, 90% of respondents said that they would join QItalktime again, which is great feedback to get. The website, we've been working on that, and you'll see in 2019, 91% of the people who answered the questionnaire had availed of the website, which is fantastic. And I see somebody is asking there about the PowerPoint slides, and yes, they will be available for people to get on the website. So if you go on to qualityimprovement.ie, you'll find the slides and the recording of all the webinars up there for people's use. So the next question was about whether people were using that facility, and yes, 85% of people are actually going back and using those recordings and slide sets, which is fantastic, a great resource for people. So don't see any further questions, just a few comments. So
thank you for those comments.
So thanks for that. Fergal Walsh is saying he's from Loughrea Dental Department. Thanks, great learning during lunch hour, fantastic. So please join us again, Fergal. And a few other suggestions there coming in the chat box, which we'll address. Thank you for those. So just to say, we will be running talk time every 2 weeks on a Tuesday at lunchtime at 1 p.m. Our next speaker, we haven't had an improvement story from the ambulance service in a long time. So Eamon Byrne, who's a colleague of mine that I met through actually doing the myself in RCPI is going to deliver an improvement story from the ambulance service, so hopefully you'll get some insights from that. And please email myself or Naomi, either if you have any comments or want to be joined up to the QI Talk Time mail list. You can email us on those email addresses. And
I guess tell people about it, because it's a resource that we'd like everyone to avail of, or anyone who can, and we'd love to build it into, as I say, a virtual community. Yeah.
Great. So thanks again for joining, and hope you are all speaking up for patient safety today on the WHO Patient Safety Day, and we'll hopefully see you all next time on QI Talk Time. Thank you very much.
Thank you.